From your own experience, research, and experience in managing people, what is it that we most underestimate about the psychology of aging?
I've treated many elderly individuals over the course of my professional career. In my opinion, it's imperative that we don't fall victim to the trap of language structuring thought in assuming that the elderly represent a monolithic age cohort, who by virtue of their age are the same or even similar, since there's considerable variability in how different individuals function differentially in their lived lives. For some seniors, not all, I've identified some pressing challenges that may be at issue. One has to do with general healthcare risk factors, which include medical history and comorbidities, lifestyle factors, environmental and occupational factors, risk factors specific to the elderly, including physiological vulnerabilities, polypharmacy and medication sensitivities, social determinants and correlates of health, adaptive behavior, functional competencies, and healthcare system access and navigation, which becomes very, very important. I've given a great deal of thought throughout the entirety of my 50 years of professional practice as a clinical psychologist and almost 74 and a half years of living life. Erik Erikson, who is a noted famous psychologist, hypothesized that as we age, the lifespan developmental challenge of that chapter of our life is to reconcile ourselves with how we have lived our lives, either in accordance with our value system or not, resulting in a self-evaluation that we've either lived a good life with meaning, purpose, and value, or conversely, that we've fallen short. In the former appraisal, one may experience a sense of what he refers to as ego integrity, in the latter, a sense of despair. I want to also implicate the role of loss for the elderly, crucial to appreciate as losses begin to accumulate and leave the person feeling increasingly lonely and alone, which can lead to a state of social disorganization, normlessness, and extrusion, culminating in a deep sense of alienation. And that word, psychobiosocial geopolitical economic, which is a mouthful, reminds us to consider the multivariate equation that each individual operates within, and this is further elaborated by their social, physical, emotional, and spiritual identity. Seniors follow appears to be correlated with an increase in longevity and in their mental health and physical health. Individuals move naturally, they engage in stress-reducing habits, they don't eat until they're completely satiated, 75-80% of fullness. They moderate alcohol consumption, they hold family close to them, and they participate in warm, friendly, and welcoming social groups. Maybe 40 years ago, then I was a young kid in my 30s or 40s, and I was invited to speak to a group of seniors, and I was shocked to discover that anxiety was almost uniformly the greater concern specific to their increasing healthcare issues, encroaching mortality, which you referenced, status appreciation, greater needs for supervision, structure, and support, and almost universal anxiety and fear of outliving their money. Interestingly, anxiety can sometimes trigger the fight versus flight syndrome, unless one allows anxiety to overwhelm their feelings with guilt, shame, doubt, or humiliation. And we must resist the temptation to assume, especially if we are healthcare practitioners, that we know what is best for a senior.
That's fantastic, Larry, and it's so deep that sometimes in one go it's difficult to comprehend almost. Have you written a book?
I've written probably 400 articles, some of which have been self-published and some of which were syndicated in various newspapers throughout northern Illinois.
I understand that you have developed rigorous protocols for opioid usage disorder. Why are these kind of structured tools so important, especially when it comes to caring for older folks?
There are two main protocols. One is specific to opioid use disorder. It's referred to as the NICA opioid use disorder diagnostic interview and the NICA psychobiosocial risk assessment diagnostic interview. And there are two separate diagnostic interviews. But one of the things that we've bumped up against is the decisional capability of a person, let alone a senior, to work collaboratively with their healthcare practitioners, not only to listen and hear and understand and respond to the excellent guidance of committed healthcare workers, but we have to be realistic and recognize a couple of important things here. First, patients don't always tell their doctors everything. Oftentimes, patients are desperate to communicate something meaningful to their doctors, and they're afraid that their doctors will look down their nose with righteous indignation and moral superiority, that we know what's wrong with you. Patients are suffering and they're struggling and they're trying to figure out, how do we communicate our legitimate concerns in a way that will result in some amelioration of pain and suffering. So one of the things that the opioid use disorder protocol does is it is directly keyed to the DSM-5 TR from the American Psychiatric Association. We spent 5 years negotiating with the American Psychiatric Association to get their express written authorization for us to adapt, modify, and utilize their opioid use disorder criteria in our protocol. And our protocol can provide a healthcare practitioner in a matter of moments a real-time DSM-5 TR diagnosis without needing the manual, because all the criteria is built into the protocol. But the protocol also goes way beyond what's in the DSM-5 to identify a whole concatenation, a whole array of signs and symptoms that are correlated with narcotic pain medication and other risk factors, including an inquiry about toxicology, an inquiry about harm to self and others, so on and so forth. But in order to invite somebody to open up, you have to let them know that your questions aren't garbage questions. And when patients experience, especially seniors, when they experience that you're asking a meaningful question, they scratch their heads and they say, this person is really not playing at being a doctor or a nurse or a social worker or a psychologist. This person is really and truly inviting me to risk exchanging my vulnerability in a way that hopefully will allow them to add some meaningful value to my life in a professional manner.
True. So how do you build that trust? And especially if you are a younger person and you're dealing with seniors, how do you build that trust with them so that they actually can open up?
Over the past 50 years of clinical practice, I'm of the opinion that I know what I know, and I believe I know what I don't know, but I'm now mindful and respectful of what I don't know. So one of the things that I think is a sine qua non of healthcare is to recognize people are not objects to manipulate. I mentioned that I'm a doctor of psychology and a black belt in the martial arts, but I can't make anybody do anything they really don't want to do. The best I can hope for is to earn respect, to win cooperation, and evolve trust with which to effect influence by consent. And that is the golden rule, in my professional opinion, especially to guide younger healthcare workers. Earn respect, win cooperation, and evolve trust with which to effect influence by consent. The fulcrum of trust is you. That is when deeply hidden secrets may become shared, when a human being may elect to voluntarily bear witness to their personal story, when the healthcare practitioner can shift from reacting like a technician helper to that of a healer and when authentic healing focuses upon more than just a biomedicalized set of signs and symptoms and diagnoses to mind, body, and spirit. The point I'm making, why would you even risk opening up yourself and making yourself vulnerable when some of your secrets you hold so closely just might come back and cause you harm? Now, I do appreciate that many physicians are under a time constraint, and many physicians may not have an hour to spend with each patient engaging in a deep dive of their psychobiosocial risk factors. But it is also my impression, at least in the United States, that medication errors are a big deal. And it is probably even exacerbated by patients self-medicating and not telling their doctors that they're engaging in other forms of medication. And so a physician in good conscience is going to say, well, this is the medication that I think is appropriate for your symptoms.
When it comes to these Medicare preventive screenings, they're often very brief. And therefore, what gets missed out, and how does a more in-depth assessment change the story for an elderly patient? Let's say someone comes to a physician and, like you said, they don't have enough time. So they do a more superficial assessment, they spend less time. But what is the long-term implication of that?
When I go for my annual wellness visit as a senior, the Centers for Medicare and Medicaid have mandated that there is some screening for opioid use disorder. And on the questionnaire that I am given by my doctor, there's one question: do you have any problems with opioids? Now, to my way of thinking as a psychologist, yes, no, maybe. What does the answer mean? But if that question checks off a box that a busy doctor has to check off mandatorily, it's mandated in the United States now, that question, it doesn't mean much. It's like saying, how are you? So at the risk of maybe stepping across a line of propriety, I remember asking a woman, a patient of mine, many years ago, how are you? And every time she would say, I'm fine. Until one day I went like this, and I looked at her and I said, can you please tell me what fine means to you? And she smiled and said, Doc, you're the first healthcare provider.
I remember the story, yeah.
Passed the test. And FINE was an acronym that indicated that she was not fine at all. She was expressing to me until I recognized, wait a second,
it means something else.
I'm stipulating to her use of language, but her use of language may itself be idiosyncratic, and consequently, I have a duty of care to take it a step further. And it took an extra few moments, and oh, by the way, that facilitated a therapeutic alliance that allowed me to take one of the most severely mentally ill, non-psychotic patients I ever worked with and help collaborate with her to turn her life around.
So looks like, the whole complete healing sort of approach probably comes from a mix of things which are not just medicine.
Well, medicine can take many forms. I had an incident where I was out with dinner. I was out with my wife and some friends. I had an episode where I just passed. So I was in the hospital, and I was waiting for to be brought in for a CAT scan. And I was in such a discombobulated state internally. And I was so surprised because the technician who was administering the CAT scan said, we will take all the time you require until you're ready for this CAT scan. And would it be okay if I held your hand? She's holding my hand, and I'm thinking, whatever is going on with me right now, hopefully we'll find out in terms of the diagnostic workups. But this moment of human connection was so important. Even if you are the one who helps so many other people, right now it's important.
You're the one who needs the
This is where things can change in a heartbeat.